one part in the chapter one is one topic that will be covered later on. That is a part of the quality. That is the PDCA cycle and all that. So somebody will other cover it. Otherwise, later on I will cover that. So today I will take a new chapter, that is the hospital as a system. Last lecture we have talked about this hospital as an organization. Now we will see how the hospital that works as a system. So before understanding that, we must understand what is our understanding about this system. What is actually system? Anybody wants to tell uh, anything about what is your understanding? What is your perspective about the system? What is system?
Sir, good evening, sir.
Good evening. Good evening. Good evening, sir.
Sir, as the name suggests, a system is basically comprising of different components and an overall setup so that it runs as a well-oiled machinery, sir. And that is a system, sir.
Mhm. Good. You
Sir.
told very correct thing. The system means it's a kind of combination of the lot of components and all that. But if you take the actual definition and actual meaning, it's a comprises of lot of components. But that component should also be interrelated and the interdependent. Until unless components are not interrelated or interdependent, you cannot categorize as a system. That is one basic character of the system. And what is the purpose? To achieve a common goal. System can be any type. It may be the physical, conceptual, organizational. And main thing is that in any system, there are three things, which is the input, process, and the output. And one more thing, that is a feedback mechanism also. And there are some kind of boundaries. But the system works in some kind of boundaries. You have to define the boundaries, in which boundaries system is running. And this input, process, and output, as in last lecture, I have told that before this input, now there is a stakeholder part, suppliers also. CPOC, SIPOC, and the C is that is the customer feedback. So this feedback mechanism is very, very important. And all these three components, they all work together. They produce some kind of work synchronized, and they produce some kind of services or some kind of product as a objective, as a common goal. Now, question arises: what is your understanding of set of interrelated and the interdependent? What do you understand by this interrelated and interdependent? These are two words. Mostly they are used interchangeably, but actually some difference is there between the interrelated and interdependent. So anybody wants to elaborate this? What is your understanding with some example also? So that will be nice. And particularly in case of a hospital, so it will be more uh, fruitful for others also. Okay. Actually, if we talk about this interrelated means components, whatever the activities are there, they are interconnected, they are associated. But in case the other part is not there, still that component can work. But they are not totally reliant on that. They can work independently also. Of course, there may be some kind of shortcomings or something like that, but they can work. And if just want to give you some example how it is interrelated. If you take the example of in the hospital scenario, radiology and the cardiology, these are the two different kind of departments. But sometimes cardiologists need some kind of imaging, some kind of echocardiograms and all that kind of thing. But if these facilities are not available, even the cardiologist, he is able to treat the patient, he is able to prescribe the medicine based on the clinical system. So these component or this system is, you can take it as an interrelated kind of thing. They can cardiologists can work. And we talk about if interdependent means one component cannot work or should not work without the assistance or the help of the other. And typical example you can say in the hospital scenario, it is very common thing, that is the OT, operation theater. they are always supposed to use sterilized item, means they are anytime they are dependent on your sterilization unit of the hospital or sterilized item. Sometimes sterilized part may be outsourced or something like that, but they are OT operation theater that is dependent on this sterilized item. Without sterilization, they cannot use any equipment, they cannot use any linen, they cannot use any kind of endoscope, they cannot use all sorts of things which are being utilized in the operation theater. So in that scenario, we can understand कि those components they are actually interdependent. So hospital is actually a system of all this kind of, as a lot of examples are there. You can think yourself also, whatever the examples are there. So system is the mixture, or system is collection of all these kind of activity in the hospital. So that is the basically system, interrelated and interdependent. That is the key word. Now we talk about something characteristic for just point of view to writing and all. Interrelated components we have already talked. Interdependent components we have already talked. There must be some kind of purpose or goal. If OT operation theater is there, there is some purpose की operation theater में लोगों की surgery होगी, and there must be some kind of specific objectives कि किस type की surgery होगी depending upon your inputs and all. Then system है, then there is input, process and output. That is also there. Without the resources, you cannot process things and you cannot produce the result also. If your hospital they don't have any gynecologist, so of course you cannot do any kind of LSCS. You cannot perform any kind of antenatal surgeries without as a gynecologist. You can consider they are the part of the input. So that is not there. You cannot do the process, and when the process is not being done, output output will not be achieved. But there are certain situations also. That is your part to think. There is process also, input also. Even you are not getting the output. So this is a scenario where you have to think which kind of scenario in the hospital that can be also happen. And in system, always there is a feedback mechanism, and that can be forward mechanism. There is a backward mechanism. Feedback means back लिखा हुआ है. It means हमेशा back में चलेगा. But in the management perspective, sometimes it's a backward feedback mechanism. Sometimes forward feedback mechanism also, and sometimes counter current kind of thing. मतलब the function is going on, and you are getting the feedback from all the persons, all the stakeholders who are involved in some kind of performing some functions also. But then you have some kind of boundaries also. You have to define hospital. If you take hospital as a system, you have to define certain limits. And you have heard one word, that is the scope of the hospital, the scope of services of the hospital. So what is actually that? That is actually you are defining the boundary of your system. Means कि आपके हॉस्पिटल में if gynecologist is not there, so always you have to see that services is not in the scope of your hospital. If your hospital doesn't have endocrinologist, you have to mention you don't have endocrinologist. If your hospital doesn't have any knee joint or any joint specialist, but ortho is there, you have to specifically mention कि ortho surgery are performed, but joint services they are not impaneled. सेम टाइम गायनी में होता है कि देर आर टू केसेस, वन इज द नॉर्मल केसेस, वन इज द हाई रिस्क केसेस. वेरियस हॉस्पिटल दे राइट इन देयर स्कोप ऑफ सर्विसेज हाई रिस्क प्रेगनेंसीज आर नॉट टेकन. मतलब दे आर नॉट एबल टू मैनेज द हाई रिस्क प्रेगनेंसी. हाई रिस्क प्रेगनेंसी मीन्स लॉट ऑफ थिंग्स which make the pregnancy high risk, various factors, that is the multipara, some abortion study, lot of things are there in that, so I'm not going into the detail. So you have to define your boundaries also. फिर system is dynamic nature. Hospital they always react with their hospital. And what is the example of this dynamic nature of the hospital? Anybody can give that? How you think the hospital is dynamic in nature? They are able to adapt the change in their internal and external environment. Very common example. Sometimes you see some kind of train accident or something like that that happens, and there is mass casualty or something like that. In that scenario, you have to see the hospital has to activate their disaster plan, and that disaster plan includes expansion of your services, expansion of your bed strength and all that. And in the defense forces, it is a very common practice. We used to do a lot of disaster drill where the casualties are more than expected, and you have to expand your services. You have to put into some extra kind of resources, which is planned under this disaster management. So that is why hospital is supposed to be dynamic nature. You cannot deny in the time of crisis or time of some kind of mass casualty. You cannot deny that we are not going to help it out. At least you have to plan for that, and that's why all the hospital they are supposed to have some kind of disaster management plan. Hierarchy always, if there is a system, some hierarchy may be there, supra system may be there, and some smaller system may be there. If you talk about, if you take the our body is something like organization, and organization a lot of systems: gastrointestinal system, cardiac system, cardiovascular system, central nervous system, urogenital system. All that kind of systems are there. So they are the part of the system. And in urogenital system there are various some sub symptoms. क्या सब symptoms होंगे? Urinary bladder is there, prostate is there, urethra is there. They are also called as the subsystem. So in the system there is a kind of hierarchy in the whole part or whole organization. That is, that hierarchy has to be maintained. So this is the basic characteristic of a system. Whenever you see something like that, you have to find out what are the components which are present in your particular, you are talking about some function or some kind of organization, whether this is present or not. Now we will see how the hospital is working as a system. Abhi tak we just understood actually what is the system, but now see in the hospital how it is a hospital. Now you see, hospital is a very complex, adaptive organizational system that delivers healthcare services. Okay. An important thing is that it is an open system. Open system means it interacts with the external environment. Okay. Means hospital has to interact patient. They are coming from the various places. Okay. The hospital has to communicate with the regulators, law regulation, regulator, biomedical management, and all that. Hospital has to interact with the insurer, supplier, and they are all the part of the external world. Matlab they are behind the beyond the hospital system. So that is why hospital is always considered as open system. Any system, if somebody can tell that that can be taken as a closed system, any system you, if you can tell which is considered, which can be taken as a closed system. Okay, these are the few points which I am telling in between, and if somebody is taking any kind of notes or something like that, you can note it down, and later on you just do go and analyze yourself what are the things, what maybe there's something like that. That is the aim of this class also. Now we talk about key components of a hospital system. As everybody knows, there are the clinical services. There are a lot of OPDs, IPD, ICU, surgery, pharma, and a lot of the other things, lab and all that. Then we have administrative services, HR, financing, bill, medical records. Then we have some support services, that is housekeeping, maintenance, dietary, security, and all. Then we have separate diagnostic services also, that is the lab, radiology, pathology, etc. And nowadays, emergency and the trauma services, they are also considered as separate. Now there is a separate emergency and trauma department as decided by the National Medical Council. Initially, it is a part of the hospital. Now this is a independent, interdependent kind of department in the hospital. Okay, there is HOD, there are SR, there are JR. They are dedicatedly posted to the emergency and the trauma services. So, but abhi now it is not being it is not being adopted in all hospitals and the medical colleges, but gradually this kind of arrangement, whichever has been told by the NMC, is supposed to be adopted by everybody over a period of time. Then emergency and trauma services, they become this such kind of services. उसके बाद these are something for the exercise purpose, which already I have told you. Interconnected system कौन कौन से होंगे, goal oriented होगा, input process output process model होगा. In these things you can you can take the example of lot of services of the hospital. Okay, so this is just for make you understand how you can do the practices. Now we talk about this challenges is managing the hospital. अब where there are various interdependent and interconnected, interrelated components are there. So there may be some challenges in managing a system also. Okay, that is the coordination complexity. That is very important. Balancing clinical and the administrative function. Being an hospital administrator, because you all are going to work as a hospital administrator in the hospital, it is a very tough and the most challenging work. You have to make the balance between the clinical part of the hospital, that is the basic revenue generating part of the hospital, because they are only who are producing some kind of revenue to the hospital. Otherwise baki rest of all, even administrative and all that things, they are just supporting them. Okay, so definitely the person who is so much of important, there may be some ego problems, lot of things are there. तो उसको आपको कैसे बैलेंस करना है, दैट इज योर एडमिनिस्ट्रेटिव स्किल, हाउ यू हैव टू मेक द बैलेंस एज एन हॉस्पिटल एडमिनिस्ट्रेटर. So that is why this course has been designed so that you can understand ki what is going in the clinical side also. Until unless you are not aware about that, it is very difficult to control the thing. क्योंकि control का it's very simple funda. When you know the things, then only you can do the better control. If you are not knowing the things, believe me, you cannot control anything. So that is the main thing. Second, that is the resource constraint. Hospital में हमेशा you find this thing. डॉक्टर नहीं है, आदमी नहीं है, ये नहीं है, वो नहीं है. This resource constraint you have to manage. मतलब limited resources में you have to optimize your functions. That is the big challenge for the administrator. You have limited resources, but even you are supposed to provide a quality treatment to the patient. And if you are not able in any circumstances, if that is beyond your scope or something like that, you have to just if patient comes in the emergency, you just give some primary treatment, and later on you can ship the patient to some appropriate hospital or the medical facilities where further he or she can take the adequate treatment, whatever is required for them. Okay. Then we can talk about this quality versus cost states of. This is again a very argument kind of statement or argumentative kind of things, where people think ki quality, if you want some quality, you have to pay for that. In some parts, it may be true, but believe me, when you work in the hospital, yeah, when you will work in the hospital, it is not like that ki quality is very costly. Ultimately things are the process. If you are able to improve your process, then automatically quality will be ingrained. That will be visual. If your process is not effective, your process is not enough competent, you cannot produce any kind of quality. And problem, biggest challenge or biggest lacuna, biggest problem in the hospital is that we are not focusing on the process part. हम प्रोसेस पार्ट पे उतना फोकस ही नहीं करते. When we start focusing, when we get some kind of adverse output. While as if you are doing everything as per the SOP, standard operating procedure, there is a very less chance of failure, or there is a very less chance of some quality compromised outcome. Okay, so that is why it is always necessary as a hospital administrator, you must design the SOP for the various areas, so that same activities can be copied in the same manner, rather than every time new people they are doing the same thing in a different kind of manner. So that SOP is very much required. Then in the challenge part, if you see that external pressure, lot of external pressure on the hospital, policies हैं, government के regulations हैं, patient के expectations हैं. Government policies, when the biomedical waste management it was came, it was came into the existence. जो small छोटे nursing home थे, hospitals थे, दो तीन बेड वाले हॉस्पिटल थे, they had a very significant problem because biomedical arranging the biomedical waste management is not it is a costly affair. You cannot do something like that. But later on, dhire dhire things are being sorted out, and some different kind of rules or some different kind of sub rules are being created for such kind of a small organization also. So everybody has to manage the biomedical waste management. But there are various, you can say, deviations and the modifications are there for different kind of people. So if somebody teach this biomedical waste management, then I think that will be properly covered. So these are the some government regulations where you have to face the challenge, and you cannot ignore the government regulations. You have to adapt them. You have to follow them. And patient expectation is also a very big challenge. If you have created some kind of brand or something like that, patient when he come to the hospital, he is expecting or she is expecting the moment he or she just drop in the hospital, immediately this would be attended by some hospital personnel and all that. So patient expectations are also on that kind of thing. And actually, quality, if you talk about the quality is a very individual or the subjective thing. One thing may be quality for me, that may not be quality for Dr. Kavita or Karnal Negi. It may not be that. So that is why actually, if you talk about the definition about this quality means expectations. जो आपकी expectations है, वो कितनी reality में convert हो रही है. So it is actually the ratio of the perception perception upon expectations. आपका जो expectation था, if it is perceived, मतलब it has been met, then it's a quality. And when this ratio is more than one, then that kind of effect is known as the wow effect. Matlab that is beyond the quality. You didn't expect something like that. Sometimes in the airlines this happens. You have taken the ticket for this uh, कौन सा class हो गया आपका normal class, and because of some scheme or something like that, all of a sudden when you boarded in the plane, you had been informed कि, oh, sorry matlab it's a congratulation, your seat has been upgraded to the executive class, business class or executive class. So that gives some kind of wow feeling kind of thing. So when this perception upon expectation ratio is more than one, that is a wow feeling. Otherwise, perception upon exception when is it is one, that is the ideal condition for the quality. So now you can understand कि हर एक आदमी की इंडिविजुअल है डिफरेंट काइंड ऑफ एक्सपेक्टेशन. तो उसका जो परसेप्शन होगा वो भी डिफरेंट होगा. तो उसके लिए क्वालिटी है सम डिफरेंट काइंड ऑफ मीनिंग. So that's why maintaining the quality in the hospital is a very challenging kind of thing. Okay. And insurance policies, lot of insurance policies, they keep on changing. Insurance sector ka there is a different problem, and that topic will be covered in some health economics. Somebody is teaching, he will cover or she will cover this topic. How this insurance policies they are working, what are the problem with the insurance policies, what is the cherry picking, what is the moral hazard, all these kind of problem hospital is facing. अब one word just I want to tell at this plate, one is that is the moral hazard in the insurance. होता क्या है, when you have taken this insurance, you know you have the insurance, then you start visiting hospital unnecessarily when even it is not required for a small kind of cough, for just you want to check your BP, because you have this insurance policy, you just walk in the hospital, and actually that is not needed. And this happens when there is the scheme that is cashless. Just say if I talk about this our defense scheme also ECHS, which is 100% cashless, and believe me, utilization is okay. A lot of people who cannot afford the treatment for the cancer, for the transplantation, for the kidney diseases, they are getting benefited. But same time, many people are they are misutilizing for just cough. They are consulting the pulmonologist. They for just a gastric problem, some gas issue, they consult the gastroenterologist. Why? Because just they have the free kind of thing. कि उनके पास कार्ड है, एनी टाइम दे कैन विजिट द हॉस्पिटल. So that thing is called in the insurance sector, that is the moral hazard. Hospital, as an hospital administrator, you should also be manage this thing. Why? Because that kind of person, they are unnecessarily occupied the time of your valuable and very important kind of specialist or the super specialist. for just cough. So as an administrator, you have to think upon that ki how you can streamline this thing in your hospital. Sometimes we have to create some kind of primary care, a doctor also. Matlab, first the patient should come to that particular doctor, and if he feels the doctor has to go some specialist, then he will route to the patient. So a lot of things can be done. Still, it is under the discussion in the various organization ki how we can reduce this moral hazard, unnecessarily visiting of the hospital just because you have the insurance from the company. Okay, this is one. Just for your thinking, as I told you, you think digital platform enhance hospital system efficiency. Now, you have to think upon this. I'm not going to tell anything about this. This is just for your thought process. It's not like that. So you have to just think upon that how digital platform they can enhance the system efficiency. That is one thing. Now we talk about the different perspective of the hospital. There are various perspectives, so I will take one by one and not going into the very detail, but just perspective means there are hospital where there are many kind of components. So we have to take first one is the structure perspective, where we talk about the hospital structures, clinical OPD, administrative area, hierarchy may be there, unit, team, cath lab, all that kind of thing, infrastructure, building. Example, may if you see, hospital emergency department has dedicated space, TRIACE, trauma bay, all these kind of things. So these perspective is the structural perspective of the system. Matlab, when you are thinking the system, in accordance with the structural perspective. That is this thing. Second perspective may be functional kind of thing, where you talked about this input process and the output, workflow and the process. They are the functional perspective, which convert process that converts the input into the output. The input may you have to think about different department के हिसाब से you can think upon that. किस तरीके का होगा? If you take about the patient journey in a system, initially, patient come to the hospital, patient is registered, then he goes for the consultation. And if consultant, he writes some kind of test, he goes for the test. Again, he come back to the consultant, show the report, investigation report, and then consultant advise the treatment, sometimes medical treatment, sometimes this surgical treatment. And if it's a medical, some kind of surgical treatment, some patient needs admission, then they are being admitted. Then after completion of the treatment, they are being discharged. And after the discharge, the important part is that we should do the follow up also, which is not being done by many hospital, small hospital, big hospital, branded hospital, corporate hospital. They do this kind of follow up. Even after the discharge of the patient, they make a patient group where they keep on interacting with the patient. Okay. So that is the functional perspective. If you see human resource perspective, we talk about यहाँ पे we see the key element. What are the key elements? Doctor, nurses, technician, and all that. And interpersonal collaboration is there. Surgeon, anesthetist, and OT staff. Until unless these three they are not work together, the system will not work. Okay, they have to work together. Without anesthetist, surgeon can't do any operation, and without OT staff, even the anesthetist and surgeon they both cannot operate. Okay, that is important thing. In the hospital, as I said, there are a lot of hospitals. They are making some kind of board, cancer board, tumor board, or some kind of cerebrovascular board. All these kind of boards are there. There may be radiologists, oncologists, surgeons, depending upon the which kind of board they are there. If we talk about this technological perspective, यहाँ पे we can think about telemedicine, AI diagnostic. Now it is there. EHRs, electronic health record. Okay, medical device. If we talk about ventilators, robotic surgery system, integration between labs, pharmacy, and the patient record means electronic health record. Again, EMR, electronic medical record kind of thing. The patient write on the computer that particular thing that goes to the pharmacy or that goes to the lab. Lab person he just open it, log in, and he opens it and he see whatever the investigation advised. He does the investigation or put the result into the system. Again, it come back to the doctor and he sees. So that is a technological perspective also. And nowadays, a lot of AI is being pulled in this medical field. Okay, So that is again a separate topic. I'm not going into the detail at this place. Then we talk about this economic perspective, revenue stream. In the hospital, there is a system for this economic perspective also, insurance reimbursement, out of pocket payments, government funding. Okay, कॉस्ट सेंटर में टॉक अबाउट सैलरीज होती हैं हॉस्पिटल में, इक्विपमेंट के ऊपर खर्चे हैं, ड्रग्स के ऊपर खर्चे हैं. एंड व्हाट आर द एफिशिएंसी मैट्रिक्स, इकोनॉमिक एफिशिएंसी मैट्रिक्स, दैट इज द बेड ऑक्यूपेंसी रेट आपके हॉस्पिटल का कितना है, एज अ लेंथ ऑफ स्टे कितना है. दीज आर सम वेरी इंपॉर्टेंट थिंग. And one very important concept is there, that is the diagnostic related group. It is a total, you can say, new topic in the India. And recently, WHO and World Bank, they have done some project in the India to understand this DRG concept. And as in a hospital, it may not be written in the book also, but recently it has been some kind of study was done by, because I met one person, I have asked them, I interacted, and then I came to know actually what is this the DRG, about how DRG is going to work. So now I just want to give you some kind of brief. It's a good thing if you are aware this DRG, that is a diagnostic related group. This is a system, this is a classification system of the patient in the hospital. And for what is the purpose of that? Purpose is to standardize the healthcare payment. And that is based on the diagnosis, procedures, age, and the other factors. Okay. And this DRG, diagnostic related group, feature is that patient with similar clinical conditions, treatment cost into the categories that is supposed to be same, and the same amount is going to be reimbursed to the hospital. Now, if you see, question arises, ki what is the difference in the present system? What is the difference between this DRG and the present system? अभी जो हमारे पास इंडिया में जो पेमेंट सिस्टम है, स्टिल इन इंडिया दिस डीआरजी इज नॉट बीइंग ऑपरेशनल. वर्ल्ड बैंक एंड WHO, they have conducted the study, and it may be it is going to be implemented in the India also. Presently, what is actually being done in the India, it is fee for services. Whatever the services you are getting or you are availing, for that you are being given money. But this DRG concept is that this is value, this is value for outcome. Okay, this is not this is value for fee for outcome. Fee for हाँ आउट, दिस इज a fee for outcome. यहाँ पे वो नहीं है कि आपको ये देखना है कि सपोज एग्जाम्पल मैं आपको लेके समझाता हूँ, डेट विल बी मोर इजियर फॉर यू. इन द डीआरजी किसी का नी ज्वाइंट का ऑपरेशन होना है, नी ज्वाइंट सर्जरी होनी है, तो डीआरजी पैकेज इज देयर. आई एम जस्ट टेकिंग द एग्जाम्पल, डोंट थिंक लाइक दैट कि नी सर्जरी इतने में होती है. जस्ट आई एम टेकिंग वन एग्जाम्पल कि नी रिप्लेसमेंट है, तो डेट कॉस्ट, चलो वी टॉक इनटू द डॉलर ऑल्सो. तो दिस कॉस्ट, that is a $15,000. ठीक है, अमेरिकन डॉलर. दिस इज द DRG price, diagnostic related group price. Okay, in any condition you are getting this amount only. Now you see, if hospital is able to manage, optimize their function, they can do this surgery even less than this, matlab they can increase their profit margin. Sometimes they are able to do this surgery into the 10,000. So now their profit is 5,000. Okay. And sometimes if they do some recklessness or they do some kind of carelessness, so what happens? Infection may be there, post-operative infection may be there, and patient is going to stay in your hospital for more time, and that then extra cost, whatever is incurred on the hospital, that is not going to be reimbursed to you. You have to manage in this $15,000 itself. Now see what is the benefit of this DRG. First, hospital has to make revenue, maximum profit revenue. तो वो क्या करेगा? They will give you quality treatment. They cannot compromise with the quality, because the moment they compromise with the quality, patient again will come back to you with complication, and you have to treat them free of cost. So no, I think nobody will think upon this thing कि पेशेंट वापस आए फिर हम उसके ऊपर पैसा खर्च करें. वाइल एज हिंदुस्तान में अभी क्या हो रहा है, इंडिया में क्या हो रहा है, इफ यू टेक सम ट्रीटमेंट in the hospital, Suppose we have taken some treatment in the hospital for the same knee surgery, and its expenditure was total 15,000. And after the discharge, patient has developed some kind of knee pain or some kind of surgical site infection or something like that. So for that, again, the hospital is going to be paid. That is the fee for service concept. फिर हॉस्पिटल को पैसा मिलता है. So that concept is in the India. Now I hope कि with this example you are able to understand what is the difference between the fee for service and this diagnostic related group service. And you can think upon that कि which practice is more beneficial. I hope कि everybody is agreed that DRG system is more appropriate and more, it should be more acceptable kind of things. Okay. So this is a value. DRG is a value based care, and in some insurance scheme, I think CGHS and ACHS, they're also planning about this DRG model after this study. That is very important to understand. So this is a very important concept which I just want to make you understand. As a hospital administrator, you should know this thing, and if you are knowing this thing, that things itself make you stand out some difference. So I hope you understand this diagnosis related group billing.
Sir, I have a
Somebody,
question.
हाँ.
सर जैसे कि अभी ये जो ग्रुप चलता है कैशलेस का, तो इसमें हम जो सर्जिकल साइट इन्फेक्शन 3 मंथ्स के लिए लेते हैं, डिस्चार्ज पेशेंट के लिए कि 19 डेज के लिए, तो सर डीआरजी के टाइम पे मतलब ये 19 डेज तक पेमेंट होल्ड करके रखेंगे देन ये प्रॉफिटेबल होगा? क्योंकि अभी भी तो यही होता है कि पेशेंट के साथ मतलब एक्स्ट्रा किया ही जाता है, जो भी उनका जो है पैकेज है उसके अलावा भी उनसे जो है मतलब कैश लिया ही जाता है.
हाँ, तो नहीं, ये प्रॉब्लम, दिस प्रॉब्लम इज वेरी गुड क्वेश्चन. दिस प्रॉब्लम इज also in some portion it is also existing with the DRG also. ऐसा नहीं कि DRG is total free of thing. There is a chance of, उसमें क्या होगा, DRG में क्या होगा, then they hospital they can avoid to take some serious patient because there is a chance of less profit. They have to spend lot of money. They will take such kind of cases which is a very simple kind of cases where they expect for the over a period in the hospital you can expect if from this patient that kind of case you are going to earn more profit. So that hospital can do that. वो कर सकता है वो. That is called the cherry picking. Okay, that is again the one term which I want to tell you in the insurance part. That is all the cherry picking. मतलब वो selected case को ले सकता है. That one lacuna is there also. And sometimes to meet their DRG cost also, sometimes they can discharge the patient at early stage. मतलब they want to reduce the average length of stay in the, because the more the patient stay in the hostel, the more the expenditure is there. It may be later on, it may be कि patient may not get 100% cure or something like that, and again he can come back to the hospital. But if you see the point, कि ultimately loss is with the patient. Because it's a medical thing. Whenever you lose something, it cannot be reverted back in the same manner. So that problem is again with DRG. ऐसा नहीं कि DRG is the 100% proof kind of thing. Okay. So DRG and the second DRG से प्रॉफिट मे बी देयर कि जो आपका कोडिंग पार्ट होने से जो आपका रिइंबर्स पार्ट है दैट विल बी गोइंग टू बी फेयर. अभी जो फी फॉर सर्विसेज में है देयर आर वेरियस थिंग्स फॉर विच हॉस्पिटल दे चार्ज सेपरेट अमाउंट फॉर एनी काइंड ऑफ कंज्यूमेबल्स और समथिंग लाइक दैट. वो पेशेंट को जो इंश्योरेंस का जो अमाउंट है एंड कोई चीज एक्स्ट्रा लग रही है तो उसके लिए वो सेपरेट सेपरेट मांगता है. इसी तरीके से डीआरजी में भी चांसेस है कि कोई ऐसा प्रोसीजर हो विच इज नॉट कवर्ड इन द डीआरजी, उसके लिए सेपरेट परमिशन लेनी पड़े, बट वो चीजें थोड़ी सी कम होंगी. दैट्स व्हाई आई टोल्ड कि दिस इज नॉट बीइंग इम्प्लीमेंटेड इन द इंडिया राइट नाउ. One only study has been conducted by the World Bank in the association with the WHO. These practices is this DRG practice is being followed in some European countries, some in Australia kind of thing. And some other countries also they are following this DRG kind of practices. Okay, so every system has some kind of pros and cons. No system is, I think, 100% proof. And if you take my opinion, I would suggest the system should be like that. Some kind of involvement of the patient means 100% cashless. करने की बजाय if we make it some kind of proportionate, कि 60% will be given by the company or the insurance company, and rest of the 40% you have to pay during the treatment, and later on that money will be reimbursed to you. So that kind of concept also will reduce the unnecessarily visit of the patient to the hospital or something like that. So there are a lot of models you can think upon that. As an hospital administrator, you have to think upon all these things. Okay. So that is the economic perspective. I hope you now you have clear some concept.
Yes, sir.
Okay, and later on you are
Thank you.
all free. You are all very that kind of mind. You can think upon that. A lot of ideas can be generated by you, all of you people. Purpose is that only ki if you start thinking like that, you can generate a lot of ideas. Okay. And then we have this socio-cultural perspective also. And in this socio-cultural perspective, we can think about this patient demographics, language, beliefs, health literacy, and all that kind of things, community trust. Now, in the hospital, as an administrator, sometimes you have to become very culture sensitive for this migrant population. You need some kind of interpreters in the hospital, and you have heard this word halal, jhatka, and all that kind of thing. There is a particular community, they only eat this halal kind of food. So you have to take care of that. This is a cultural sensitive care. Okay. In one hospital where I was working, there are some South Indian patient was there. So he has been served idli in a normal kind of plastic plate or something like that. He doesn't seem very happy or very delighted with that kind of approach. And later on, when we interacted, ki why this food was not tasty or something like that, so the expression of that lady was there ki if it could be served in some kind of banana leaves or something like that, that will give more wow kind of experience. So as an hospital administrator also, we should be enough cultural sensitive for the patient. But one thing is that for getting this cultural sensitivity, it should not be you should start avoiding the advice of the dietitian. You should start avoiding the direction of the doctor. Because of their hospital, there is a chances of the infections, lot of other things are there. So you have to take care of that also. But in any case, you have to very much um, pro for this cultural sensitive environment also. And same thing, ethical issues. Now it is also India, it is also going to be legalized later or sooner. End of life care. This is a very important thing. In the world, there are few countries who are considered where the people goes for this end of life. End of life. Matlab, they want to finish. They want to just get off from all kind of life support system at the terminal stage. And that particular tourism, जैसे health tourism होता है, उस tourism का भी एक particular नाम है, which I am just missing. Sometimes if I recollect, I will tell you that there are few countries where people only go for that if they can end their life, because in that country that is legalized. Norway and all that type of countries where these things are legalized. So yeah, end of life care, maybe you have to take care of that, how you are going to manage as a hospital administrator. Then this we talk about this
Sir,
regulatory and the legal. Yeah.
sir, just to interrupt, you were mentioning about euthanasia, sir.
I am talking about the euthanasia.
Yeah, okay, sir.
So that there is a peculiar term for this. उसका जैसे हम हेल्थ टूरिज्म की बात करते हैं तो उसके लिए भी एक peculiar term है, just I have forgotten that. And there are few countries where people goes for this practice only, euthanasia के लिए जाते हैं, where that is legalized. So that is peculiar term has been given for this tourism. Okay. Then we talk about this regulatory perspective also. Lot of accreditation agencies are there. You know this JCI, NABH. HIPAA is not still in the way India में उतना नहीं है. This basically deal with the data privacy in the USA and all that. But again, India they are also drafting their this data privacy rule and all that kind of thing. Then we can talk about this medical laws. These are all the perspective, system perspective. Medical laws, you have to, as administrator, you have to see malpractice liability is there. There are a lot of surgeons and the doctors or some other stuff. They are doing some kind of malpractice. You have to check that. You have to ensure the patient right also. As in hospital, gate should not be violated or it should not be compromised. And for maintaining the quality and all, you have to conduct audit, infection control protocols. Lot of things are there. And now these systems, NABH accreditation or JCI accreditation in the private hospitals and the government hospital is the NQAS. They make ensure that a minimum quality is supposed to be followed by the hospital. But in ground level, we may say a lot of things which I don't want to discuss at this place. That is off the record. So there are lacuna, or you can say there are some kind of malpractices in maximum system is there. How we can minimize that? That should be our concern. Okay. Then we talk about this environmental perspective. किसी system का वो भी एक perspective होता है. Hospital, they are generating lots of lot of waste. You have to manage a lot of biomedical waste management so that it cannot harm the community or it cannot harm your staff also. Same time, you should think about the sustainability also, and it is the sustainability of the light, sustainability of the fuel. So you have to use lot of solar lights and all that, rainwater harvesting. These all the environmental perspective, green hospital, all these kind of things. Okay. And main thing is that you have to properly dispose this biomedical waste segregation. And second is that the concept of the green hospital where the you are using all these kind of things means solar light, and this solar light. Besides solar light, you have to use some kind of less consuming electricity kind of thing, CFL and all that kind of thing. So you have to think upon that, making the green hospital. It is not only that you make the garden and all and the hospital becomes green. You have to use the transportation to internal transportation, and that is the intermural transportation. You can try some other kind of fuel which cannot produce the give so much of carbon dioxide and all that kind of thing. So that is all the part of this green hospital. Even the rainwater harvesting, that is the part of this green hospital. Sound is also one thing that is part of the green hospital. Natural light, you have to make sure whatever the hospital design is there, that should give some kind of natural light. So all these things we will going to discuss in the hospital planning. That is the third chapter, which is the next chapter. And that is a very long chapter. It is going to be, I think it will take much more time. More time. Most of the time of your course that is going to be in the hospital planning. As a hospital administrator, you have to understand that. Then we have the system thinking perspective also. If the system is there, there must be some kind of perspective, thinking perspective. Means you have to have some kind of feedback mechanism. You have to have some kind of adaptability, disaster response. You have to be there, and sometimes hospital reputation as a result of all subsystem. If it is not like that, any hospital they can get some kind of good or bad image with a particular kind of things. So there are many things which are interrelated that gives your hospital some kind of good image, branded image, or sometimes it may ruin the hospital image also. Okay. And system thinking perspective ka one example, if you think TAS protocol is there, but in the COVID time, you have to sometime you have to redesign or remodify this TAS protocols also. That's a triaging is there is one more word that is known as the reverse triaging. One is the normal triaging when you see the serious patient, red and green and yellow kind of patient, red, yellow and the green kind of patient. But there are few scenarios where we do the reverse triage also. Means the person who is more serious, they are being looked after by in the last. And that particular reverse triaging, whether it is common, anybody can tell or anybody can think about this reverse triaging where we are doing that. Colonel Leggy, I expect answer from you on this aspect.
Sir,
Reverse.
reverse triage can happen in cases sir, where we are looking at the preventive measures sir, rather than the corrective measures, sir. Like for example, if you are a very crude example, sir, suppose if you are having your supplements of vitamin after you cross 40, let's say for example. So you are doing a triage. You are not trying to solve a problem based on red, yellow, or something. You do not want a situation to exaggerate to a level where it becomes red, yellow, or green, whatever it is. So I think a
So,
preventive kind of a approach would be more suitable to a reverse triage, sir. I mean, that's
okay,
my
that is a good.
sir.
That is a good perspective of your side. You have given any thinking. Otherwise, in the defense, it is a very common thing. If you talk, actually, triage is that if you are triaging the patient, that is based on the clinical condition at that time. It is not a future kind of activity. In defense, it is very common when war is going on. In the war front, you see the soldier who is the less injured. He is first being given the treatment so that he can go back on the war front and he can fight also. So that is the thing which is very common in the defense. जहाँ पे जो आपका जिसको कम चोट लगी है पहले उसको देख के हम उसको लड़ाई के मैदान में भेजते हैं. Later on we focus on the person who may be losing his limb or her limb or something like that. तो वहां जो सीन आ जाता है वहां पे दूसरे तरीके का रिवर्स ट्रायल हमें करना पड़ता है. तो दैट इज वेरी कॉमन इन द वॉर काइंड ऑफ सिनेरियो वेयर वी नीड more fighting fit people to further take on the war. So that is a reverse kind of triaging in the war front also. Okay. And what the Colonel Negi has told, that is a different kind of perspective. I'm not telling ki it is totally it is on the wrong side, because one thing is very important in any study or any research kind of thing. There is nothing wrong. Only you have to support your thought process, your argument with some kind of evidence or something like that. So one thing is very clear: when you complete this study and somebody goes for this PhD and all that, nothing is wrong. Only you have to prove that with your some research data or something like that. So, but it is always good. You should think something new, and it is a very good approach. I find in this MHA batch, people are something like that who can think something not very typical thinking. That is a very appreciable and very, you can say, delighting things for me as a faculty. So today I stop at this point. Okay, and whatever the things, whatever the few small things I have told in between, that you are supposed to think upon yourself how digital technology they improve the efficiency of the system. That one question I have told you, and you get more and more example of this interrelated and the interdependent kind of thing. Just make yourself some kind of clear concept, and you should think about this DRG. It is a very interesting topic. So I would request everybody. Normally, nobody will people used to teach this DRG topic. It's a current topic kind of things. But since I have told you this topic, please go through that, and you also explore ki, you also start comparing ki which is better in the Indian context, whether it is value for services or fee for service concept. So you have to think upon that. Okay. With this, I just stop at this point, and in the next lecture day after tomorrow, we will start the hospital planning. That is a very important topic and interesting also. You come to know as a hospital administrator what 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 you can't do that. As a hospital administrator, you can do many things. You can plan hospital, you can administrator hospital, you can do anything. Only thing is that you have to get some kind of knowledge, and later on you have to observe whatever has been is being taught in the class into the hospital scenario, and further you can improve that. Okay. So, thank you to all of you, and we will meet on again day after tomorrow with new topic. Okay. Till then, you keep on thinking whatever I have told you, and you can tell in the next lecture whatever some new ideas or some new perspective you have developed. It's always welcome. Okay. Thank you. Good night. Good night, all of you. Thank you.
Thank you, sir. Good night.
Thank you. Thank you. Thank you.